planning.
Hannah, was there a quorum at the last meeting?
I do not know.
So making sure there are no other minutes, the other minutes were approved.
Later, then there was another.
Okay, I couldn't remember. I just want to make sure we didn't have a set of old minutes that still needed to be approved. Sorry, Hannah.
All you.
Good afternoon, everyone. My name is Karen McKinney. I'm the Indiana Pathways for Aging and Hoosier Care Connect Director, and I'm happy to be with you today.
And I am Shannon Effler. I'm the Director of Care Programs for OMPP, which means I have oversight of all of our managed care programs, not only our compliance with CMS, but also the compliance of our health plans, which we call managed care entities, to the state. So happy to be with you today. And apologies to those who were also at the Commission on Aging and have to sit here our presentation one more time.
Next slide, please. Just as far as the agenda today, we've done our introductions, and these are some of the things we're going to touch on. We will be talking about the pathways awarded MCEs. We'll also be talking about the onboarding and readiness review leadership team, managed care onboarding and readiness review and what those entail, post go live monitoring, the things that we'll have in place once we do go live so that we can continue to monitor after that. We'll talk about informal caregiver support requirements, housing support requirements, and then a discussion following that. Next slide, please. So when we talk about pathways, what I like to say is basically what's up here, which is OMPP will contract, and it's on a statewide basis with managed care entities to deliver risk-based managed care services to beneficiaries enrolled in the state of Indiana's risk-based managed care, long-term services and supports program. A lot of times you'll hear it the MLTSS. It's my understanding, after a lot of discussion and deliberation, they decided to come up with what we have today, which is the Indiana Pathways for Aging. And sometimes you'll hear it as just Pathways for short. And Pathways is the enrollees are for folks who are 60 years of age or older, and are also eligible for Medicaid on the basis of age, blindness, or disability. Next slide, please.
Okay, some of you may be very familiar with this slide. This is an overview of the many initiatives that are occurring targeting Indiana's long-term services and supports reform, overall reform. I highlighted the move to Indiana Pathways for Aging in 2024, which is the move of long-term services and supports from fee-for-service into managed care. That's what we're talking about today. But all of these other initiatives are occurring to move us to our goal of 75% of new LTSS members will live and receive services in a home and community-based setting. So those are faster eligibility, getting people eligible for Medicaid faster and for nursing facility level of care, pay for outcomes, not transactions, so really focusing on quality of outcomes, not just that transactional relationship. Moving towards an integrated LTSS data system. This one is, I know, top of mind for all of us, supporting the growth, retention, and training of the HCBS direct service workforce, creating a home health roadmap, and integrating our HCBS waivers. Next slide. So regarding pathways, we have three major goals for the program. These goals were developed through stakeholder, member, and provider input. The first is person-centered services and support. So our goal is to ensure that we develop service plans and deliver services in a manner that is person-centered, member-driven, holistic, involves caregivers, and addresses social determinants of health. Goal number two is ensuring smooth transitions. We all know our healthcare system is very complicated and transitions occur all of the time. So we want to ensure that those are as smooth as possible for members. This is also a goal around the major transition that will occur when we go live with this program, right? And folks are moved from fee-for-service into managed care. And a portion of Hoosier Care Connect members will also move into the Pathways MLTSS program. Goal number 3 is access to services, really honoring member choice. We have some work to do here in Indiana, ensuring that members can choose the setting of their choice. Right now, there just aren't the home and community-based services that are needed to really honor someone's choice, right? So we want to ensure timely access to appropriate services and supports to enable members to live in their setting of choice and promote their well-being and quality of life. So these are the 3 overall quality goals for the program. This is what we're working with the MCs on to make sure that overall their delivery of services really connect to these 3 goals. Okay, next slide. So who are the managed care entities that will be delivering Pathways? So these are the 4 that were recommended for award through state's RFP process. So they are Anthem, Humana, Molina, and UHC United Healthcare. I want to emphasize it's recommended for award. So that means that based on their proposals that they submitted to us, we are recommending that these are the 4 that should deliver Pathways, but that is contingent on their passing of a readiness review, which we're going to detail for you what exactly is a readiness review of MCEs. So at any point, an MCE was not performing up to our standards, then we have the ability to stop moving forward with that managed care entity. So they're really in a period of proving themselves to us. All right, next slide. Here is a chart, a table that outlines some information regarding the 4 recommended award MCEs. So Anthem will actually be our only MCE that will be delivering all 4 of our managed care programs. So HIP, Hoosier Healthwise, Hoosier Care Connect, and then Pathways, dependent on their performance. Anthem is a familiar name. They have over 11 million members across 26 states in the US. Their LTSS program experiences, they are currently serving 416,000 members across 10 states. And they're one of our largest DSNPs. They have, so a DSNP is Medicare dually eligible special needs plan. The acronym is DSNP for that. And so they have an active DSNP of 40,000 members here in Indiana. Humana does not operate Medicaid in Indiana currently, but they do have 1 million members across 5 states that they serve. And then their LTSS experience across the nation is they're serving 40,000 members in 3 states. But they do have Medicare experience in Indiana. They currently operate a DSNP where they're serving 23,000 members. Molina is the one MCE that is going to be new to Medicaid in Indiana and new to Medicare. Yes.
Is Humana's DSNP population their Advantage members?
I don't know.
No, so Medicare Advantage is separate from the DSNPs.
So these would be traditional, these 23,000 would be traditional Medicare participants?
No, so a DSNP is a managed care plan. It's for those folks that are specifically dually eligible for Medicare and Medicaid. Medicare Advantage is just a Medicare.
Right.
Managed care.
I'm just trying to get my head around it. So these are just 23,000 Hoosier Medicare recipients who happen to be served by Humana.
Correct. And I see Dr. Council came off mute. He is our DSNP, our Medicare Medicaid coordination expert. So he may be able to clarify more.
Yeah, you'll remember that Medicare Advantage is the term used for general managed Medicare. But Medicare Advantage plans can apply for a special needs plan. One of those types is a dual eligible special needs plan, a DSNP. So a DSNP is a Medicare Advantage plan, but it's a special one. And a DSNP is allowed to only enroll people with both Medicare and Medicaid. So Humana has Medicare Advantage plans, and a number of people, I don't know the numbers, are enrolled in that, but there are 23,000 unique individuals that are signed up for their dual eligible special needs plan.
Thank you.
Sure. And then our fourth is UHC United Healthcare. So they currently serve Indiana Medicaid members through Hoosier Care Connect. But nationally, they have close to 8 million members across 32 states plus DC. And then their LTSS experience is they're serving 350,000 members across 10 states plus DC. And they also operate a DSNP in Indiana with roughly 30,000 members. So those are our 4 recommended for award managed care entities. Again, that is contingent on them passing the readiness review with the state. Next slide. Okay, this slide is a little bit busy, so forgive me, but this is our overall pathways implementation timeline. And you'll see where the cursor is, kind of the second cohort thing right there. It says March 2023 to June 2023. And it says that we are in the managed care entity onboarding, technical assistance, and readiness review planning period. So Karen is going to walk through exactly what is onboarding, but wanted to highlight that's the period we're in right now. Then in July, we will kick off readiness review. That will continue until we go live with the program in July 2024. And then also want to highlight, and Karen will talk a bit about this too, once we go live with the program, and we operate compliance monitoring of all of our current managed care entities. That is something that the state does that will continue with pathways post go live, and it will be very rigorous and thoughtful for especially the first 6 months of go live of the program. And that'll be dependent on how things are going, how we decide to operate that. It could be that we do a very rigorous oversight for a year, 2 years, whatever. It's dependent on what's going on at that time. Okay, next slide. Stakeholder engagement. So I am really proud of the FSSA team that we have held over 600 meetings with stakeholders. So these could be one-on-one meetings, these could be group meetings where we are talking to them about the Pathways program. And that's occurred in a roughly short amount of time, in about 2.5 years. The governor publicly announced that we were reforming LTSS in early 2021. And really since then, we have been engaging stakeholders nonstop to get their input and feedback on not only the scope of work, which is the contract that we have with the managed care entities. They have helped us design it, but also all of the associated materials with it, such as our policy and procedure manual for the MCEs, our caregiver assessment, which I'll talk about later, really all aspects of the program. And also want to highlight that 92% of stakeholder considerations were either fully or partially incorporated into the scope of work. This log was hundreds upon hundreds of pieces of input that were provided to us, and we carefully reviewed each of these and made a decision on whether we were able to fully or partially incorporate it, or we had to pass just because, for example, is outside of regulation or something like that. We knew CMS would not allow us to do that. So really just want to give thanks to all of you who have participated in this, but also, give kudos to FSSA and the state of really holding stakeholder engagement in the forefront of this whole process. And stakeholder engagement will continue post go live of the program. We have built-in member and caregiver advisory committees into the Pathways program. We have built-in provider advisory committees into the program. So stakeholder engagement will certainly continue. And I'm going to pass it to Karen.
So next I'm going to talk about the onboarding process. And then after that, I'll talk about readiness review. So like Shannon said, right now we're in the onboarding process, and basically what that is FSSA engaging with the managed care entities for at least 3 months prior to the readiness review. And we started doing the onboarding presentations in April, and we'll go most likely to the end of June. We talk about and review documentation that includes the policy and procedures manual, the scope of work, the service and care coordination manual, reporting manuals, assessments, anything of importance that we need and want them to take a look at. And the FSSA agencies and the business areas provide close to an hour presentation most of the time to the MCEs that indicate at a minimum the following: an introduction to the business area, the role and responsibilities of the business area, the expected collaboration of the business area with the MCE, training regarding a specific process or function that the MCE must perform related to pathways, and the expectations for the MCEs. And once we follow the onboarding session, then the FSSA business areas will provide technical assistance, which is basically support and education to ensure that the MCEs are going to be able to meet the requirements and meet the expectations of them. Yeah.
What is the FSSA business area?
That might be a specific department within FSSA. So like yesterday, we did a
This is
presentation,
internal.
right? Internal, like might be home health or pharmacy.
Nice.
Yeah.
Okay.
And, here it says MCEs will onboard with more than 20 business areas. And I've been on almost all of them. And I would say we're at least halfway there, if not more than that, as far as getting through the onboarding presentations. Next slide, please. So readiness review overview. I said earlier this morning that what I've heard it called is boot camp, which I thought was very interesting because what I've heard is it is very intense and very extensive. Formal definition we put up here is a systematic, large-scale review of different things of the MCEs, including their staffing, their policies, their processes, documents, subcontracts, system capabilities, and their provider networks. As we advanced to the go live contract part. And there's safeguards that are put in place that all selected MCEs are ready to accept enrollment, provide the necessary continuity of care, ensure access to the necessary spectrum of providers is there, and be able to fully meet the diverse needs of our population. The readiness review also ensures MCEs understand and assist FSSA with meeting the Pathways program goals. Readiness review, it includes a couple of things. One is a desk review, and it might be of their documentation and or on-site demonstration where we go to the managed care entity and we ask them to show us their capabilities in an area possibly like a call center or systems, something like that. And what I want folks to know is the readiness review helps us to ensure that the MCEs will be ready to go live when we decide to do that. And we're continuously monitoring that and making sure they're in compliance with our expectations. Next slide, please. As Shannon said a little bit ago, I was impressed with this number that OMPP has conducted over 600 and counting stakeholder engagement meetings. I don't know that I've ever been part of anything that's that collaborative. And that's helped us gather input on the design and implementation of the program. The stakeholders and the internal FSSA staff have provided feedback on the scope of work, on the service and care coordination manual, as well as other areas that need to be reviewed and validated before going live. So we've incorporated a lot of that information into our processes. And also OMPP will engage providers on the claim submission testing during readiness review. Next slide, please. Just an overview. Historically, for readiness review, MCEs have been required to prepare over hundreds of documents. including policies, procedures, and contracts to show that they are in compliance and are ready to go live. So this has been done before. I've not been a part of the readiness review yet, but I know we have folks on our team that have, and it's a very extensive process. In addition to that, we also have at least 2 FSSA subject matter experts. We call them SMEs. You might hear that term. We have the subject matter experts review every document. So every document comes in, gets reviewed. The anticipation is that there'll be at least 40 hours of live readiness review demonstrations to occur from each MCE throughout the course of the readiness review. So not just one MCE, but the 4 MCEs. FSSA subject matter experts attend those demonstrations, and they determine if the MCE is compliant with the program and readiness requirements. Additional demonstrations are requested until readiness can be verified. So if we don't feel like we're at the readiness point yet, we can do additional demonstrations. Next slide. And I said earlier, this is a tough slide to read. But for each month, we have 3 to 4 topics that we want to cover during this readiness review time. And for example, in July, we're looking at administrative requirements, staffing plans of the MCEs, implementation plans, and a list of their system platforms. Then if you look way down, I don't know if you can see it, for February of 2024, we're looking at pharmacy, we're looking at program integrity, and also non-emergent medical transportation. So for each month, we're going to be looking at least 3 to 4, preferably 4 different areas. Next slide, please. And this is just what I mentioned a little bit ago, that we have gone through readiness review before and utilize the standard compliance verification format that we have. And enhancements will continue to be made with every iteration of the readiness review to make sure it's the most effective. So we want to keep getting better and better. Next slide, please. And then post go live, everything doesn't end once we go live. We still continue to monitor the MCEs through compliance, and we can complete on-site audits. We can do the desk reviews. We can request and receive reports from the MCEs, have regular meetings, and more. They will continuously be held accountable to ensure quality service is being given to aging Hoosiers. And not only just the aging Hoosiers, but their caretakers, their providers, and everyone involved in their care. And as we continue, OMPP will make amendments to contracts and manuals as needed to ensure information remains up to date and relevant in order to promote member well-being and quality of life.
Okay, next slide. So we provided an overview of onboarding and readiness review, and I thought it might be beneficial for you all to hear just a few really cool aspects of this program that I think are going to have a really positive impact. So first is Indiana, we built in several different aspects around requirements of the MCE to support informal caregivers. And when I say informal caregivers, I'm meaning somebody who is unpaid that is involved with the member and caring for them. And the feedback that we've received from other states and trade orgs such as Advancing States and CMS is that in our conversations with CMS is that Indiana really has the highest amount of built-in requirements around caregivers. And I think that's something that we should all be proud of. And I do think that it is going to have a huge impact in Indiana. That's something that is really due to all of the stakeholder input that we heard loud and clear that we need to support our caregivers. I will say, although we're hearing very positive feedback from CMS, this is pending CMS approval, right? And because Medicaid dollars are targeted for healthcare, right? And for members who are on Medicaid, not necessarily caregivers who may or may not be on Medicaid, right? So, but we're pushing the envelope. And I think that we're going to be able to do this. So MCEs are required to provide training, education, and resources in accessible formats to caregivers. So not only do they need to honor the communication preference of members, they need to honor the communication preference of caregivers. So I wanted to highlight that. I mentioned a little bit earlier around the member and informal caregiver advisory committee. So this is, again, we're involving caregivers alongside their members. And it will be structured as a minimum of 4 regional member and informal caregiver advisory committees at least quarterly. So these are around the state. We did that on purpose because we didn't want the MCE to say, well, we're just going to have these in Indianapolis, right? So we wanted them to have people be able to physically go to these meetings across the state. The MCs will be developing their plan for this and submitting that to us for review and approval. Yes.
So I really like this. But as the MCEs are building out everything and you guys are working with them, are you having like the caregivers and even the individuals going to be on in the Pathways program, like kind of utilizing their system to try to figure out the flaws before the go live date?
Can you talk more about the flaws?
Yeah, just to make sure that it's user friendly and that they understand what, they're, submitting and knowing what they're electing as different services that they're wanting to receive through MLTSS.
Yeah, so they will have to walk us through. So when Karen was talking about the demonstrations on site, so that will be literally, we will give them a scenario, a member, a caregiver scenario, and tell us, like, walk us through everything that you're going to do with this. So it's not necessarily what I think you're asking for, which is about partnering directly with the members during that process, but they will be capitalizing on all of their experience in other states on what worked, what didn't work, and learning from that. Okay, next slide. I'm still on informal caregiver supports. Next slide. There we go. Okay, so the slide I just reviewed is really about what will be provided to all informal caregivers, but also want to highlight a couple more that will be for those caregivers of members who are not nursing facility level care. Pathways will have roughly 100,000 members in the program. About 80,000 of them will not meet nursing facility level care. I think that's something to keep in mind. It was designed that way on purpose to help know that somebody who is very healthy and 62 years old could stay in the program as they get older, right? And they would still be connected to their systems of supports, and the MCE would be able to proactively and preventively address items. Dr. Burke, yes.
So for clarification, so these could be people on the choice program.
They could also be eligible for choice services.
Because it wouldn't be nursing home.
Well, so choice, you don't necessarily have to meet nursing facility
Right.
level of care. You can have 0 to 1 ADL. So those folks in theory could also be on Pathways, or folks who meet nursing facility level of care could also be on Pathways.
Right, so the care, I guess what I'm trying to say is for informal caregivers of people on choice who didn't meet nursing home level of care, they were on choice, would receive some of the service.
If the individual is enrolled in Pathways, they would. The member has to be enrolled in Pathways to receive these
Okay.
services.
Yes. Yes.
To be enrolled in Pathways, they have to be Medicaid eligible.
Correct, yes.
Right. So if they're,
Medicaid eligible.
what's that, Joanne?
If they're Medicaid eligible, then are they choice?
Well, I think this goes to the disconnect that we've talked about before, which is that we're divorcing choice from waiver. When we move waiver away from the AAAs are still going to administer choice. They're not going to administer waiver. They may be providing some case management for waiver, but they're no longer administering waiver. So the question has never been answered as to, there's been this great synergy between the two programs. So we're losing that synergy. I think that gets to the heart of your question, right, Joanne?
Right.
Yeah. So talk about that if you would, Leslie. I mean, we've talked about it before and I've just never received a satisfactory answer.
Sure. So I get what you're saying. So today, the AAAs, they do case management for the A&D waiver. So for about 34,000 folks and independent case management companies provide about 12% of case management for that population as well, or 12 to 15%. In my mind, I do still think there is some synergy at opportunities there. One, we do have that 50% requirement where we've got 50% of service coordination under pathways will be provided by the AAAs and the ICMs. So they'll still have that connection there as well. The other thing that we've been working on is kind of mapping out what all of those warm handoffs will look like and what those touch points will look like, and facilitating the MCEs having that close relationship with the AAAs. I will point out some of the work that Dr. Council has been doing over the last couple of years on duals coordination and working with the AAAs and MCEs and having work groups and really building that connection and that relationship. So there can be referrals and connections there as well. So, I mean, it is something that we do continue to work on and build into our processes. And certainly if there are areas where you guys see, you know, we can make improvements, we can work through that more, we can talk through that more. Happy to continue to talk about that.
Well, I think one of the issues that has come up before that, again, I'm not sure we've received an answer to is, will the waiver provide all of the same services that are available under choice?
Under choice.
Mhm.
Today, I mean, yeah, today there are some things available under waiver that are not available under choice.
Yes,
But-
there's some choice services under choice that aren't available under waiver, like handy chore or information and assistance aren't waiver services.
So we're not changing any waiver services and move to pathways, I guess, or we're not limiting or eliminating services.
Right. But I think you just contradicted each other because Leslie, you said that there were, if I understood you correctly, there are waiver services that are not available under choice, but all
Correct.
choice services are available under waiver. But Aaron, you said that there are some
Like
choice
information
services that are not available under
assistance
waiver.
But not the
So,
the
yeah,
in-home
so-
services.
Right, so assisted living, for example, is under waiver but not available under choice. So they don't marry up 100% today.
What about home modification services?
That will continue to be offered under waiver.
The same as choice with the same ADL qualifications.
Yeah, I believe so.
Well, the choice eligibility criteria is not changing, so it could still be 0, 1, 2 ADLs. Or 3 or more if the individual doesn't qualify for Medicaid. But once an individual meets nursing facility level of care and they're on choice, and if they have Medicaid, then they'll have to transition to pathways.
Right, but like you said, Leslie, if the AAA is doing 50% of the case management, then the folks who happen to be in that population will have access to any choice services that aren't available under waiver. But the folks who aren't receiving their case management through the AAA would have to be referred to the AAA for any choice services.
Correct.
So that just seems like a disconnect. Has that been addressed?
So I mean, I think there are lots of programs today that the AAAs don't administer where we do referrals and warm handoffs to the AAAs, and the 50% is a floor, not a ceiling. So it could very well be more than that 50%, but there is incentives for the MCEs between the care coordinator and service coordinator to really be connected to those community supports and doing those warm handoffs, whether it's with the AAAs or with other services that might be available to the individual.
So your question, Joy.
We're getting for. Well, I still have some questions. But perhaps my questions will become clearer as I see this roll out more, but.
Well, I think when we did the DDRS waiver transition presentation a few meetings ago, we talked about in future state doing like a case study, sort of a walkthrough of a member experience. And so maybe that's something as we're moving through implementation for us, we can put together like a walkthrough of if Jane is on choice and she has 0 to 1 ADLs and then she progresses, what does that all look like? How does that all work? And maybe that is a good way we can kind of map
That would help immensely.
Dr. Council, I see you came on camera. Is there anything you want to share?
Yeah, I might just reiterate the strong collaborations that we're building through the work with the dual special needs plans that all include United Healthcare, Humana, and Anthem. And proactive referrals by the health plans, which will continue to be done by the MCEs under pathways, whether or not the person's in their the companion Medicare DSNP program. And so that's to really identify anyone with long-term services support needs that would be flagged for a referral. So not kind of depending on, and that tracking would continue to be done. So anyone in pathways, they're already fully Medicaid. So the only reason that they would be eligible for choice as a non-waiver program through the AAA is if they don't meet functional eligibility for the waiver program. So they're not quite nursing facility level of care. And so this is exactly why we're proactively referring people from either the DSNP or eventually the MCEs to the AAAs, and really emphasizing the unique relationship there as the AAAs being the access to all other non-waiver, non-Medicaid home and community-based services that are listed on this slide and otherwise.
Thank you. All right, so again, back to requirements that the state has put into the pathway scope of work for MCEs. We require the MCEs to coordinate resources and supports that the informal caregiver needs. So they're coordinating, they're referring, they're connecting, they're doing those warm connections, warm transfers out to community supports, food banks, housing, utility assistance, all of that for caregivers. Again, that's amazing because these folks may or may not be eligible for Medicaid. Okay, and then for members who are nursing facility level of care and they have an informal caregiver, I mean, the MCE is incentivized no matter if a member is non-nursing facility level care or nursing facility level of care to really support that caregiver, right? Because that will allow that member to reside in the home and community for as long as they can safely, right? But for those who are nursing facility level of care, we want to provide even extra support to involved informal caregivers. We've developed through stakeholder input and partnering with the Regan Street Institute, IU Center for Aging Research, we've developed an evidence-based informal caregiver assessment. So this is really awesome where we are going with the members' permission to work with their informal caregiver, allow the opportunity for the informal caregiver to complete this assessment, which will give the managed care entity information needed to further support them and connect them with appropriate resources or provide those resources to the caregivers. Additionally, a side benefit of this is that this data will be provided, de-identified, but this data will be provided to the state. So the state will have a snapshot into what our informal caregivers of nursing facility level of care Medicaid members experiencing. And that will help inform our policy and how we move forward with aging policy, but also any refinements that we need to do to the Pathways program. So we will be analyzing that information as it comes in. And then the second bullet just identifies what I just shared, that based on the results of the caregiver assessment and their preferences, the MCE will provide access to resources that would support and assist the informal caregiver in their role. And this is also in addition to authorizing waiver services that are connected to caregiver supports and making sure that those are in place, such as structured family care, informal caregiver coaching and behavior management, or self-directed attendant care. Okay, next slide. And this is our last one. So housing, again, pending CMS's approval, we're really pushing the envelope here, but we all know how important members having safe and stable housing is, as it connects to their health, right? So we want to ensure that the MCE is being proactive in supporting members around housing. You'll see if you've read our scope of work, we have roughly 27 key staff requirements, which means this is a key staff position that we want the MCE to hire for, and it has to be fully devoted to Medicaid lines of business. Some of them also have to be fully devoted to just the Pathways program, such as the housing coordinator. So this is a really cool position where they will be responsible for overseeing housing services and support for Indiana Pathways for Aging members. They'll also be involved in transitions of care. So for example, if a member transitions out of a nursing home and wants to go back to the home and community, they will be partnering to ensure that that is a safe transition and as smooth as possible of a transition. So again, kudos to the state, kudos to FSSA for putting this into place. And there are some additional requirements listed here around housing support. And I will say that we released, so obviously the MCEs responded to a scope of work in the RFP. And so they have committed to doing this, right? So we know that they're not going to push back on us and say, well, hey guys, you're not paying us enough to provide housing support. They said they're going to do it. So I think we're moving in a really fabulous direction with this and that it will have a positive impact for our community. Yeah.
So I think this is a good example of one of my concerns or something I wanted to ask about. You talked earlier, or maybe Karen did, about ongoing review, meetings and the audits and all those sorts of things. So talk about that in the context of this housing initiative, which I think is a great concept.
Yeah.
But one of my longstanding concerns has been, how does an MCE that is covering the entire state of Indiana develop community level connections and competency when it comes to, again, using some of these as examples. So it's easy to put all this on paper or put it in an RFP and have an MCE say, yeah, we'll do it. But what is the ongoing review going to look like on this, for example? What are the expectations for the MCEs and their subcontractors to develop, knowledge of and relationships with moving assistants and advocacy and negotiation with landlords and other tenants? I mean, is the expectation that the MCE is going to have someone physically present in the community who's going to go out and cultivate all these resources and be in contact with folks? This has come up before in the context of our transition on what is it, 211? I wanted to say 811, but that's what you call before you dig. 211. I think I have that correct, right? But like in New Albany, for years, we had a person who had a physical office in New Albany, and she lived in New Albany, and she was the 211 coordinator, and she went to community events and knew all the players with all the nonprofits and, knew who the landlords were. And if somebody called and they needed housing, then, she had a current list of referrals to say, here's where I'm aware of housing. How is that going to look here? Because when we transitioned away from having a local 211 and we went to I think our 211 service may even be out of state now. So somebody at an 800 number is being asked, where do I find housing in New Albany? So that's a lot, but I think it gives you an idea of my concern and how that relates to the review and the expectations.
Yeah, so I feel like I could talk a long time, like approaching this from different angles, but one, I'll say that we have, for those 27 key staff, which housing coordinator is one of them, the MCE has to provide to us a resume, skills and background, a biography of that individual that we review and approve. And that doesn't just stop during readiness review. We do that currently for key staff of MCEs. So we will be looking for what experience do they have in this area? Do they have a background, to your point, of being connected with those community supports? How are they going to be able to fulfill the responsibilities of the position? And then secondly, they have to develop their internal, like I always call it a program, meaning like, so I really want the MCE to understand that this is proactive and that they need to be thinking about all the things that you mentioned. And they need to submit that to us for review and approval. It'll also we'll also request things such as policies and procedures of how are they educating, because this is one position, but really the face of an MCE, for most folks, is going to be the member services rep, like the person where they call their health plan, they have questions. We want that person to know like about these services and supports in the community and to be able to say, okay, I think you need to talk to your care service coordinator, or let me connect you with the housing coordinator. So really making sure that the education doesn't just fall on the housing coordinator, that everybody's educated about what's out there and when to know. Because a member may have a care and service coordinator, but they are just going to pick up the phone and call, and they may not remember that person's name, and that the member service rep is able to connect them to the appropriate individual. As far as building relationships, an MCE is going to want to do that. Do we dictate that specifically in the scope of work and say, you must build relationships with all of these folks? I mean, no, because what we're requiring them to be are experts in this. And in order to be an expert, they have to have that knowledge base. They have to have those relationships. Does that help?
What helps? I'm not sure I buy it. To be frank, I'm worried that people are going to get passed around from one person to another, and ultimately their issue is not going to be addressed or addressed timely. So the housing coordinator, for example, is the expectation that there will be one housing coordinator as one of those 27 key positions with each MCE.
Yes.
So, again, it's a great concept, but is that housing coordinator going to be up to speed on how eviction court works in Elkhart and Evansville and Madison and Indianapolis, and, be able to act timely to help prevent eviction in a meaningful way, rather than just having, a generic resource that says, if you have someone call the care coordinator who's threatened with eviction, then refer them to legal services. And then that just is too often too late at that point. So I want to make sure that it's meaningful and it's actually going to address needs, not that we just have a list on paper that, again, is a great concept. But I'm having trouble seeing how, again, using my example of eviction court, how is one person with each MCE going to, going to address that for all of their members throughout 92 counties. Just an example.
Well, I will say that the key staff we're requiring is that full-time housing coordinator, but that is not to say that they won't have additional staff under them, right? It's just that we are not dictating that to them. But I will also say this is very valuable input. And I think what we can do is Karen can take back to her team, really creating some scenarios around members who are in Evansville, Elkhart, Goshen, wherever, and really during readiness review, having the MCE walk through, here's your scenario. What are you going to do? Who are you going to connect them to? And then we can evaluate that. Like, are those really community-based resources? Are those the appropriate resources?
Well, I think it's very important to have a tracking mechanism as well, because if a member calls the MCE under this housing initiative and says, I'm worried I'm going to get evicted, then I hope the system is being designed so that that person is tagged in the system as facing threat of eviction.
Yes.
And then, 30 days later, 60 days later, 90 days later, there's follow-up and reporting back to FSSA.
Yeah.
In the aggregate, how many threat of eviction calls did our member services line get in the month of May? And, as of August 1st, what percentage of those people still have stable housing? I mean,
Yeah.
those are the things we need to be measuring. It's not enough just to say that they can call and ask for help. What matters is what percentage ultimately get connected with services that, in the
Yes.
case of eviction, prevent eviction from occurring. But I go back to the ongoing review that I held off on asking about earlier. And again, I think this is a great example. Are those review expectations baked into the contracts?
Well, what's built into the contract is that they have to basically do whatever the state asks them to do and provide whatever we want them to do.
Yeah. Or maybe a better way to ask it, Shannon, is are you developing or will you develop a standard operating procedure with respect to minimum review standards, that there will be, so many of this, you talked about meetings and audits and other things that were up on the board there. So that, at a minimum, we'll be doing this number of this thing and this number of this thing and this number of this thing every quarter or every year with every MCE. And then if there's a noted deficiency, here are the next 3 things that will be done automatically.
Yes, so we have the readiness review log that Karen talked about. That outlines for readiness review. What are we obtaining from them? What are we
Right.
asking them to demonstrate? And then post go live, we will have what I call compliance program, which is what are we doing each month? What are we monitoring? What are we looking for? And that will also be developed over the next 6 months or so.
Okay.
But I don't want to lose sight, just highlighting for Karen, your input regarding our managed care reporting manual. I think we can take that back. I don't know off the top of my head what reporting requirements we have in there related to housing. So we will double check on that too.
Yeah. I just think it's important that we measure things in the aggregate, but it's also important that we have a system that minimizes the chances that individuals are going to be left behind.
Yeah.
Even if the
course.
overall numbers look good, even if,
Yeah.
the MCE can report that they answered, I'm just making up numbers, they answered 89% of calls within X number of minutes, and
Yeah.
they've got all these statistics to say how good things are going, how well things are going.
Right.
I want to know what happened to
Oh, I know.
individuals.
Yeah, that's my life. And especially with this population, one member falling through the cracks has severe consequences. So I hear you for sure. It's top of mind for us.
Yeah. Well, I appreciate what you're doing. I just think the devil's in the details,
Mhm.
and, the real world, the way that some of these things may play out in the real world, I think is going to be, it's going to be difficult to provide the level of responsiveness that I think is needed. So
Yeah.
I'm glad that you're sensitive to what we're
Yes.
discussing here. And it's not a criticism. It's just, I've been asking these questions along the way because I think, many of us share the same concerns or similar concerns.
Of course. And I will say that I think I shared a few months ago, we had our team here, which is the Pathways and Hoosier Care Connect team, and we are fully staffed with them. And so they are ready to go, and they're already working with the MCEs and reviewing information. And so I'm really proud of that. And I will say that the sentiment I share, being sensitive to that, they all share. They're all doing this because they're very passionate about older adults in the aging community. So I think that we can rest assured that we're going to do everything that we can for them.
And the go live date is when, in 24?
July 1st, 2024,
Yeah.
that is dependent on that we can go live with the program well at that time, right? So if we want to launch this program as soon as we can, because we do believe it's what's best for members, but we're not going to do that if we don't feel like we're ready or the MCEs aren't ready.
And we still think it's a good idea to do this in the last 6 months of a gubernatorial administration.
Well, that decision is not up to me.
Just saying,
I know.
I hope you've signed all of the key players to 3-year contracts, so nobody will jump ship as 2024 winds to a close. And folks I'm half kidding, but I'm half serious.
I know, yeah.
As we typically see a lot of folks look for private sector positions as we get to the end of an administration. Jim has certainly seen that. Am I wrong?
No, it happens every time.
Yeah. So I'm just, I would hate for us to be, it's sort of like the countdown at NASA, when they go down it's Apollo 13, they go to each system and, go. And then half the people get up and leave. That wouldn't be good.
No, we're not.
Yeah. You don't want the staff fleeing to join the MCEs.
Mhm. Yeah, and for the Pathways team, they actually aren't allowed to go to an MCE for 12 months post-employment. The state has a non-compete, so if you had oversight of a contract and you can't go work for that contractor for at least 12 months post leaving the state. So that is a safeguard around that, but it's also just an ethical concern. Yeah.
I just wanted to, excuse me, go on what Representative Claire was saying, just in a natural. I am just a normal retired person now after 45 years half was in home care and half was in senior housing. And my husband recently, and we are Medicare only, traditional plan, but he recently had to have a back fusion. And I told, between our doctor and him, 15 people that he was to be outpatient, and yet they still sent him to the inpatient wing. And we had to literally fight tooth and nail all day long to get out of that. And I'm a very educated person, and I knew all the people to talk to and demanded different people to come to me. So when we have someone who's in their home and they're being faced with this, and you say, call a number. I called every person. I met with every person. I shamed every person during that day experience of, reading their mission and saying, how can I tell 12 people and I'm participating in my patient plan of care when you're not honoring that request? And the physician has said, we can go home. So I think that that's the concern we have, and why choice originally, I was on a committee when that was first started. It's the people between the cracks that we are most concerned about, with that we're challenged to make sure we're defending their rights too. And so I think that's all we're concerned about. We don't want that crack to be any bigger. We can't care for the people now that need choice, much less bigger cracks. But I also commend the training as well for the caregivers. I said to Joanne, nurse to nurse, that's what home care is supposed to be. You're supposed to teach the caregiver to help take care of the patient. And somehow that got turned upside down along the way. So that's wonderful. And I'm glad we're addressing that.
Thank you. Yeah, very valuable input. And again, want to just say that the caregiver supports, housing supports, these are some of the really innovative aspects in our Pathways program. It's not all, but I'm really proud that we have built this program to have these requirements. And then I think our last slide is if there's any further discussion.
Do have one other. I'll bring up an oldie but goodie. We've talked before about the reimbursement plan for the AAAs with respect to case management, and then also the assignment plan as to how cases will be assigned to the AAAs. So I know those both get into some fairly technical areas. I think we've heard before, it may have been you, Leslie, who said this, that the the AAAs will be a subcontractor of the MCEs, and the way that you determine reimbursement requirements for subcontractors is different than the way you determine it for the actual contractor, but all gobbledygook aside, I want to make sure that the AAAs receive a fair and competitive reimbursement rate for the case management, and that the assignment of cases is done in such a way that they receive a fair allotment of cases, that they don't get disproportionate share of extremely complex or difficult cases, nor do they receive disproportionate share of easy cases, that they should be treated the way other case managers are in terms of assignment. So can you either of you speak to both of those?
Sure, I'll start and then obviously chime in. So on the reimbursement rate piece, yes, like we talked about, they are subcontractors. So the waiver service rates won't apply to the service coordination because it will be built into the MCE capitation rate that we pay the MCEs, and then they will subcontract with AAAs or ICMs. That being said, I mean, we share your concern. We want to make sure that their subcontractors, whether it's the AAAs or ICMs, are paid fairly. And the MCEs have an incentive to make sure they are paid fairly, because we will have quality standards and requirements that the MCEs will be held accountable for. And it's their job to make sure their subcontractors are supported enough to meet those requirements as well. What we hope to have is an ongoing conversation with the AAAs, and we've been meeting with them monthly since December, just to talk about this transition and these changes and what questions we can answer for them and that sort of thing. So that as they step into this new phase here, where they're starting to negotiate with the MCEs, and I know Kristen will have an update that I think the MCE or I think the AAAs are going to be in a really strong position from a negotiating standpoint. But our goal is to have that open dialogue with the AAAs. So if they're feeling abrasion points, if those negotiations aren't going the way that they hoped, that we're there as a partner and can help facilitate those discussions as well. So part of it too is service coordination under pathways is not an apples to apples to case management today. And so there's potential undercutting too. If you kind of set like, this is the rate for case management today, go forth and use that rate for service coordination. So we didn't want to have challenges with that as well. So I mean, that's the approach that we're taking with that piece. On the case mix, I think there's something in the scope about the case mix allocation, right?
Yes.
Yeah.
Yes. So we have caseload ratios of staff to member ratios. Because what AAAs will be serving, they'll be serving as a service coordinator, which is only for folks who are nursing facility level of care. Service coordination is not offered to all pathways members. Care coordination is offered to all, which is also an innovative, great thing about our scope of work. Most MLTSS programs don't have that. But we do have requirements around the caseload of the service coordinator to members.
So the service coordination is available for all members who are nursing home eligible,
Yes.
but care coordination is for
all.
everybody else.
Well, all, including those that are nursing facility level of care.
Aren't those both forms of case management?
So care coordination is more of a kind of comprehensive clinical base of things, and coordinating disease management, preventive care, and also any chronic conditions that are happening. Service coordination is specifically to coordinate waiver services. We also have service coordinators assigned to nursing homes as well. So they will be working with members who are in nursing homes.
But you're saying to me, those both sound like case management, but you're saying
Yeah.
that the service coordination is the type of case management that the AAAs will be doing.
Yeah, yes.
I
And
don't-
the AAAs do now.
Yeah, I don't ever remember that distinction being made when we've talked before about case management. At what point was it determined that, the care coordination would not be considered case management?
Maybe Steve's coming on camera, maybe he wants to help, but what I will say is that care coordination is an added benefit to managed care. So it's something that in our current field, of aging services for folks who are getting case management and AAAs doesn't exist in fee for service. They don't get access to care coordination. And so this is an added benefit of managed care that they now will have care coordination in addition to service coordination. Steve, do you want to share anything?
Just a clarification of the terminology that we've tried to be consistent in using over the last couple of years is nationally the generic term for waiver care management, as we call it in Indiana, is waiver service coordination and waiver service coordinators. That's kind of the national generic CMS terminology. In Indiana, we called the waiver care managers and care management service under the waiver. And so with moving to pathways, we've tried to be consistent in our language. And so the waiver people will be called waiver service coordinators or nursing facilities service coordinators for those who have long-term, nursing facility level of care. And then on the health plan side, they will use the term care coordinator on the health plan side in terms of the nurse or person who's the designated care coordinator. Hope that helps some. That's been challenging there and we'll gradually make that transition.
Well, it helps, but I think it comes back to choice again, because we have lots of folks, somebody correct me if I'm wrong, Aaron or Kristen or somebody, but we have lots of choice participants who are receiving, who are not nursing home eligible, but who are receiving case management, right? I mean,
yes, and some will call that care management. And so there's a lot of terminology out there. It's a similar role and function as we're calling under the waiver now service coordination or through pathways. But that service coordination will be done by care managers at the area agencies on aging. I'm not sure what their job titles will continue to be.
okay. Well, again, I just want to make sure that the AAAs are treated fairly, both in reimbursement and in assignment of cases. And it sounds like you all share that objective. But
Yes.
we've talked about it a lot,
Yes.
number of times, and we've never gotten to specifics. So I guess as the rollout gets closer and closer, maybe we'll know more specifics, right?
Yeah, and I don't want to steal Kristen's thunder. I think she's on the agenda today as well. So she'll be sharing some updates in that regard. But we meet with the AAAs as a network regularly. We are next week, starting on the 22nd, we're having AAA roundtables where across the state, where we're asking each of the 4 MCEs to come and meet with AAA reps. And we're facilitating those conversations to get them to know each other and ask questions. Again, Kristen may share some more information on that as well.
I just, and we massaged it pretty well, but I just want to say, as we were going through some of the other questions related to housing, I was thinking the AAAs have to have a plan for their area that they serve. And for instance, with the housing question, they'll know their local community better. Probably, I think that's where Ed was sort of going. Then
Sort of.
oh, okay. Then someone from a more remote location. My concern in Indiana will be as we transition here, that we don't not fund the AAA, but yet refer to them because they have the local knowledge. Now, I don't know how we're going to deal with that here, but I think that's what we've been talking about, because the AAAs through the Older Americans Act, they have to, they're supposed to be looking after the older people. Well, they have concerns about the older people in their planned service area. And yet we're also saying, and this is due diligence on what we're putting together here with managed care, but it's overlapping and I'm not sure where the funding's going with some of these things, and to defer back to the AAAs but not fund them, we got a problem.
Yeah, and I share your sentiments about the importance of the AAA network. I mean, we were in, Andrew Bean and our deputy director and I were in Area 15 last week, kind of meeting with them. And, you know, you learn about all the really unique benefits that the different AAAs provide, right? And they really do step up and fill the gaps in their local communities. And so I share the sentiment of the importance of the AAA network. Funding is always something that's an issue, right? And I think that's true across the board. I mean, Older Americans Act funding is federal funding and it's limited. The choice funding, we got a little bit of extra funding in this legislative session, right, in this budget, but it's something we're always thinking about too. So I mean, I do think it's something we're aware of. It's something I want to make sure we as the Division of Aging continue to support that network, because we do have such a close partnership with them on all these programs that they administer on our behalf. And again, I mean, I think we want to make sure that they are supported, and we're going to do what we can to make sure that they are supported.
Well, and the Division of Aging is the state unit on aging connected with the Older Americans, I mean, through the Older Americans Act. So, I mean, there are just, there's overlapping things going on here, but I'm not sure the funding's overlapping.
I mean, it is, like I said, I mean, I know funding is always something that we're thinking about when we're looking at other states and how they fund some of their aging services, right? I think historically Medicaid has provided a lot of funding, Medicaid waiver funding. Other states may have more, you know, state and local supports and things like that too. So I think we are trying to be creative and looking at what are ways that we can continue to build up support for not just the AAA network, but for aging Hoosiers in general. And so that's something I know we as a division are looking at in a lot of different ways too. And certainly as we're working on pathways to kind of keeping that at the forefront.
And I thought a question you were going to ask earlier was about equity, because I know that you brought that up several times, and I don't know that we've closed the loop on that, but we have put in additional requirements in our with the MCEs around, they have to submit to us their full plan of how they're going to address certain items regarding their subcontracts with AAAs. And one of those items is geographic equity. But I do, you know, again, don't want to steal Kristen's thunder. I think the way that the AAAs are mobilizing will innately address a lot of that, but just want to assure you that we're listening, and we did put that in.
Thank you. Yeah, I believe, I mean, I share Joanne's concern. Again, I believe that in a managed care environment, there's an opportunity that we haven't really approached yet to turn the AAAs more toward prevention. And I think maybe another way of putting what Joanne just said is we don't want the AAAs to be in the position of just picking up the slack, you know, for an array of things that aren't covered well under managed care. You know, the MCEs need to figure that out without putting an undue or inappropriate burden on the AAAs. We need to start to think, the state of Indiana needs to start to think about how do we leverage the AAAs to do more on prevention. And I think there are endless opportunities there.
Yes. Okay. Thank you all. I really appreciate being here. Continue to provide your feedback and input on this. I appreciate it.
Yes. Well, thank you, Karen and Shannon, for your insight today. Do we have Stephanie here for the settings rule?
Stephanie is virtual.
I am online today. Good afternoon, everyone. Thank you for letting me join your meeting. Let me just get my screen share up here so I can pop this up. There we go. So I wanted to take some time today to update everyone on the settings rule implementation in the state of Indiana as it pertains to HCBS waivers, the time frame of the settings rule implementation, and really the impact that it's having on the sites that we are working with. So a little bit of background, the settings rule is a law passed by CMS that describes the characteristics of home and community-based services and providers. It really distinguishes home and community-based services from institutional services. It ensures that Medicaid waiver participants have rights to dignity, respect, privacy, and freedom from coercion and restraint. And it really takes a two-pronged approach. It focuses both on the day-to-day lives of the participants, so what their day-to-day experience of their waiver is, as well as the physical traits of the settings in which they live, work, and spend time. So the Division of Aging did a review of all Medicaid waiver services and determined that the 6 on the screen are subject to the settings rule. These are really the places and spaces in which people spend time, right? So waiver services such as pest control or home modifications are not subject to the settings rule, or home delivered meals, because people don't spend time in those locations. They spend time in assisted livings, in adult day services, adult family care settings, provider owned and controlled structured family care settings. I should note here that consumer controlled structured family care is presumed to be in compliance with the settings rule, since that's happening in the consumer's own home. And then they spend time in supportive employment programs and structured day programs. So these are the 6 sites that the state reviewed. Any provider who came on board beginning in 2017 had settings rule compliance sort of baked into their provider onboarding. So we had a team of 16 contractors who came on board to review all of these 6 types of sites that became providers before 2017. In total, we had about 150 sites that we were reviewing and building out remediation plans for in order to bring them into compliance with the settings rule. The settings rule was passed by CMS in 2014. So we've been talking about this for almost 10 years now. Indiana, all the divisions that administer waivers in Indiana created a statewide transition plan that outlined how the state as a whole and each division individually was going to bring all of our providers into compliance with the settings rule. That statewide transition plan was approved in June of 2022. We were working diligently before the statewide transition plan was approved, though. As I mentioned, all providers who came online in 2017 or more recently had compliance baked into their onboarding process. The transition period that CMS allowed for states to bring sites into compliance with the rule expired on March 17th of 23, which means that just a couple of months ago, we were made to ensure that all of our sites were in full compliance with the settings rule. And of course, there's ongoing compliance concerns as well that we'll talk about as we continue today's presentation. For most sites, the compliance process was a 2-step approach. First, our contract evaluators went out and did a physical site assessment. They saw the site itself. They assessed for physical accessibility of the site, things that might be institutional in nature, like assigned seats in a dining room, PA systems in a bedroom, inaccessibility of laundry, inaccessibility of the site in general in terms of doors and or concrete issues that people would have trouble navigating if they were utilizing a mobility device, etc. Each site visit also consisted of an interview with an executive staff member of the site, as well as an interview with at least one Medicaid waiver participant per site to make sure that the experiences of both the staff and the individual were in line with what we were physically observing. The second step of the compliance process was a desk review. For every single site, we reviewed every single person-centered service plan of all Medicaid waiver participants at that site. For residential sites, we also looked at leases and any supporting documents, appendices, policies and procedures, et cetera, that supported the lease to ensure that the leases and all of those documents were in compliance with the rule. Assisted living sites needed to get a DOH waiver There are some discrepancies between DOH policies as it pertains to discharge of individuals from a residential site compared to the settings rule requirements for discharge. And we know that we have to be following the federal rule, not the DOH licensure regulations. So DOH was kind enough to work closely with us to issue waivers to these assisted livings, saying that the ALs would be allowed to follow the federal regulation and not the DOH regulation. Finally, all staff and Medicaid waiver participants needed to be trained on the rights and responsibilities that were granted to participants under this new law. Following the compliance process, a remediation plan was developed for each site that outlined the items that were found to be out of compliance with the settings rule and gave benchmarks and timelines to work toward in order to bring that site into full compliance by that March 17th deadline. There were a handful of sites that were subject to what we called the heightened scrutiny process. This process applied to sites that were presumed to be institutional due to their proximity or cohabitation, if you will, with an institutional setting. So think of a building that has an assisted living on one wing and a nursing home on the other. The purpose of the heightened scrutiny process was to make sure that no policies or procedures from the more institutional side of the building accidentally bled over into the home and community-based side of the building. Once we completed the heightened scrutiny process for each site, those packets were delivered to CMS for final adjudication, and we are still waiting on the decision from CMS to determine what next steps are for our heightened scrutiny sites, if there are additional things that they need to do to truly be in full compliance and prevent institutionalization from taking over their HCBS areas, or if they're good to go and can continue to bill for HCBS programs. So some common issues that we saw during our compliance visits included issues related to physical accessibility. I already mentioned, concrete having massive potholes or lips in it that were inaccessible to individuals utilizing mobility devices. Also, all sites had to have at least one front-loading washer so that individuals could wash their own clothes if they wanted to, even if they were of limited mobility. Sites had to have automatic doors that allowed for accessibility into the site as well. We saw a lot of issues as it pertained to leases and their compliance with the settings rule. I don't think that there was a single site that didn't have to rewrite their lease in some capacity or other. Probably one of the biggest issues were limitations on visitors. So the settings rule guarantees the rights of individuals across any setting to have visitors of their choosing at the time of their choosing. We saw a lot of issues with leases around visitors not being allowed after 9 p.m. or visitors younger than 12 not being allowed to stay the night, all kinds of things like that. So we had a lot of issues to remediate with visitation. We also had issues with referral procedures. So under the settings rule, sites are responsible for helping to find new services if the existing service is terminated. So if an individual is going to be discharged from an assisted living, the assisted living should work together with the care manager to help find a new location for that individual to live in. We also saw issues as it pertained to lease termination practices that fell under Indiana landlord-tenant laws. Ultimately, all of these leases should provide the same rights and protections to the individual signing the lease as standard leases that any of us may sign would provide us. So people have to give 30 days notice before eviction. Things like that fall under standard Indiana landlord-tenant law needed to be fixed within these leases. We saw a lot of issues related to the participants' rights to privacy. Some sites are working currently on installing curtains because they might have dual occupancy bedrooms, but no visual privacy existed in those bedrooms. So we're working on that with some sites right now. Additionally, we had issues with locking bedroom and bathroom doors. So if there is a door and it's not a studio apartment, but there's a door separating the bedroom from the living space, that door needs to lock, and all bathroom doors need to have the ability to lock to afford people privacy in their living space. And then issues of staff entering the apartment, just announcing their presence as opposed to asking to be let in and receiving permission from the individual. It's a real mindset shift for a lot of folks in the assisted living world that this is truly the resident's home and they have the right to refuse entry to staff members as well, just as you and I can choose not to answer our front door if somebody were to ring our bell. Other compliance issues were related to terms of endearment, calling people sweetie or hun instead of a preferred name, or even worse, in my opinion, calling somebody by their room number. Room number 202 needs his medication now. And access to food at any time. So if you visit any of the assisted livings or adult days or any of the other sites that our team worked on, you'll probably notice snack stations pretty available to folks now so that they have access to food outside of meal times as well. One big issue that we heard from CMS during their site visit in November of some of our heightened scrutiny sites was around Indiana's person-centered service plans. Our team is working very closely with the care management team to bring these person-centered service plans more into alignment with what CMS's expectations are. Those expectations are really that the person-centered service plan drives the provision of services for the individual and doesn't just focus on ADLs and IADLs, but truly focuses on the comprehensive social supports that an individual needs in order to live life well. Ultimately, care managers will be responsible for developing the person-centered service plans together with the individual that they're representing and sharing those plans with all providers. Providers will ultimately be responsible for implementing that plan on a day-to-day basis. So what does ongoing compliance monitoring look like? I should first start by saying that we are so excited that all 150 sites were either fully or contingently approved as being in compliance with the settings rule. We have 5 sites currently that received contingent certification out of that 150 for issues like curtains that are going to take a little bit more extensive construction within the building, or for issues like potholes and concrete. Obviously, with a deadline of March 17th, we weren't going to be able to be pouring concrete in the middle of an Indiana winter. So we gave them a little bit of extra time to get those things fixed before they had to be in full compliance. But we have 145 out of the 150 that are already in full compliance and 5 that are well on their way. Ongoing compliance will happen every 3 years. Every provider will be subject to an ongoing visit. We're still working on finalizing the exact timeframe and process, but as I mentioned, all sites that became providers from 2017 to present had that compliance baked into their provider onboarding experience, which means that now in 2023, it's time for us to go back to those sites that became providers between 2017 and 2020 to bring them, make sure that they are still in full compliance and or bring them back into compliance if they've slipped a little bit. So the team is currently working on that. We have about 50 sites that became providers in that 3-year time frame that we are working on evaluating and bringing into full compliance again at the moment. That process is going very smoothly. These sites are used to what this is as they had it baked into their onboarding. This is just a nice little refresher course for them. For most of them, to make sure that everything is still going well. Another part of the settings rule is making sure that all Indiana code and Indiana administrative code is in alignment with the settings rule, and there will need to be some editing to the Indiana administrative code. We readopted the current administrative code, and then we'll begin process of amending some of those rules moving forward in the next cycle of the settings rule process. And then I already mentioned the DOH waivers for discharge rules, that they were so kind to work with us when their regulations differed from the federal regulations that we were working on enforcing. There were some affiliated projects associated with the settings rule as well. All sites were eligible to receive a settings rule grant, which assisted in the things that they needed to do to bring them into compliance. So if they needed to purchase that front loading washer, or they wanted to pay their staff a little bit of extra time to participate in some of the trainings that their staff needed to participate in. Residential and non-residential sites received a slightly different rate because we knew that the tasks that residential sites needed to undertake were going to be significantly more expensive than those that non-residential sites needed to undertake. And then in addition to that flat rate, they received $50 per Medicaid waiver recipient. All of these grants were contingent upon the site being fully compliant by that March 17th deadline. And all sites, as I mentioned, were able to achieve that compliance status. There has also been a lot of communication happening with a lot of different entities around the settings rule. We produced a number of staff trainings for settings rule compliant sites or settings rule subject sites, including a settings rule 101 done for administrative staff, and then a similar program done for direct care staff. We also produced a community integration training as well as a person-centered service planning training for all settings rule subject staff. We produced a webinar for families who have loved ones participating in adult day programs, so that they understood the rights that their loved ones had in those adult days. We've trained the entire Division of Aging staff, and we produced a person-centered service planning training for care managers. Since I've done this slide deck, we've also done a training for all Department of Health inspectors, that they understand not that they are responsible for inspecting for settings rules specifically, but if they see anything that causes them concern or they feel might violate the settings rule, they know how to report it to Division of Aging staff for investigation. And I'll stop there. I know that was a lot of information in a very short period of time, but I wanted to keep it pretty high level for you. I see Carolyn has her hand raised. Carolyn, if you're talking, you might be on mute.
Representative Jackson, are you able to unmute? She's gone.
Are you hearing me?
Now we can hear you.
Okay, great. Thank you. Okay, as I was saying, I've had quite a few people who live in assisted living in my district complain. The problem is that they have relatives and family members, children who live out of state. And when they come here to visit them, they want them to stay there with them at their apartment. However, they're being told that they have to leave by 9 o'clock. Is this something that is standard for all assisted living in facilities in the state?
No, that's not standard, and it does violate the settings rule. So if you want to send those people my way, I will drop my email in the chat. I will investigate those assisted livings. They should have the right to have visitors.
Okay. All right. That's what I thought. And in some of the instances, the person who's a resident of the facility was in a position where they were in need really of 24-hour care. Someone really needed to be there with them to help them with baths and just so many different things. And that is some of the reason why this particular individual would have visitors who would come like in shifts. And it got to the point where when the person who took the last shift would come, as they walk in the door, they would say, "Oh, well, you'll be leaving at what time?" Like that.
Oh, yeah.
Yeah, and I didn't have the answer, but I felt like that was against the rules, but I wasn't sure. The other thing that I would like to see is it be required that the rules and the regulations be posted so that family members or friends come by to visit. I'm not saying that everybody's coming to spend the night. Let's make that clear. However, if I have a relative or something that I'm coming to visit or know someone whom I would like to come and visit, I think rules need to be posted. So, so that anybody that comes in the facility if they have the need to, they can read the rules and regulations so that they'll know, along with the phone numbers to contact the Department of Aging or whoever and complain if
Yeah.
they are not following the rules, because this is something that I know for a fact that it's been happening in my district, and it has not been happening just for the past couple of months, but it has been happening for years.
Yeah.
Also,
Yeah, so it is required that they post the ombudsman and the Department of Health number for complaints. During all of our resident interviews, we ask if they know how to make a complaint and how to make an anonymous complaint. Many do not, in which case we require retraining of all of the residents at that facility. I should also note here that these regulations, so especially around the visitors, settings rule only applies to waiver participants. So you could run into instances where, in theory, a waiver participant at a site could have an overnight guest, but a private pay individual might not be able to have an overnight guest because they are not technically subject to the settings rule. I've not seen that. Most places aren't going to do two leases that are different for private pay and Medicaid, but I suppose theoretically it's possible.
okay. Also, when you go out and you do compliances check to see if the facility is in standard, do you also check the outside of the building as well? Are you just mainly concerned about the inside?
We're checking for things specifically related to the settings rule. So it is, as it pertains to the outside of the building, it would be physical accessibility. So things like potholes, lips in the sidewalk, handicap accessible doors, those types of things. I'm not looking at building structure or maintenance or anything like that, because that's outside of the purview of the rule.
Oh, it is. Okay. Well, I understand what your rule states. However, I really think that you might want to modify it and look at the building, because there is a building in my community that if you look at it from a distance, it looks really fine. However, if you really look close, you'll see that the balconies are gone. You just have doors there. So the person can come into the apartment, but the other way that they would get out should there be an emergency would be by way of the balcony, but the balcony has been removed.
Okay.
The
If you send
balcony
me that,
door-
I can run that through our legal team and see who is responsible. Just because my team is only doing settings rule doesn't mean that there aren't other teams reviewing the sites for
Okay.
other compliance issues, and I'd be happy to look into that.
Okay, I will be more than happy to send you that.
Great.
Okay, just put your information in the chat and I will make sure you get it.
Okay, I did.
Any other questions? All right, well, thank you, Stephanie.
Thanks for having me.
All right, I know that we are over time, so I'm going to pitch it quickly to Leslie for a legislative update.
Yes, and I will give a very short update. So there are just two things I'll highlight. One, which I mentioned earlier, the additional 5.5 million of choice dollars that normally would have reverted or been transferred over to Medicaid. The biennium budget allows us to keep that 5.5 million with the choice program. So very excited on that.
That's a big deal.
Yes, it is. Yes. Yes. So we're very excited for that. The other thing I want to highlight quickly is HCBS waiver rates, reimbursement rates. So we went through a pretty robust rate review process over the last several months. The General Assembly agreed to fully fund our proposed new rates, which is a pretty historic investment in those HCBS services and those reimbursement rates for providers. So Division of Aging alone, our waiver services, the state share is 157 million in fiscal year 24 and 200 million in fiscal year 25. But total state and federal funding for both of those years combined is close to $1 billion. So just a really, really great investment, something we're really, really excited about and excited to see. We are targeting a 7/1 effective date, hopefully for those new rates, but that is all subject to CMS approval. We've got a lot of different processes we have to go through with them, but we're doing what we can to get those in place as soon as possible.
Good work, legislators.
Because they're based on rate questions, okay?
So I'm on choice and choice only, I'm not in the case. And, I didn't, can somebody tell me what the flight for attendant care hours?
The final reimbursement rate.
Yes.
So we are rolling that out, that information out over the next couple of weeks. So we're having webinars with providers to kind of work through that information with them. And then it will be posted to our website. So anybody can find that on our website and look to see what the new rates are. But I will say for choice, we're still looking at the impact to choice, right? And we'll have to, that's because it's a separate program using separate dollars, the rates will be listed somewhere else. So we'll have to work on getting that type of information updated.
But I do know the rates are usually the same for the same service.
Correct. Yep.
So I guess the reason I ask that is because, you know, the things aren't really gonna improve with this home care crisis until the aides get paid more.
Correct.
Money.
Yep.
Because, you know, my aides are telling me if I don't get my increase in July, I'm gonna go work somewhere else because it's really sad that people that provide my attendant care work at a fast food restaurant. And, you know, it's just, I just wanted to know how soon that was gonna happen, because one of the things that some people are running into is when they ask whether or not there's going to be an increase July the 1st, some people are telling them, well, we don't know how managed care is gonna, and I said, well, I don't even know what it's at all, does it?
No, choice is
Okay.
not a managed care program.
Okay, I'm I'm clarifying that for myself, I need to know that. But I just really want, so you are anticipating though, that the rate structure will be in place in July 1st?
That's what our goal is, but it requires federal approval from the federal government, and there's a process that takes. And so what will probably happen is we will get approval in sometime in the fall, and it will be retroactive to July. So we will reconcile those claims from July to the date of approval to move up to that newer rate.
Okay, and then is there a requirement? Is there a requirement of the direct providers a certain percentage? Because I know that they're doing some federal stuff that might be coming down the pipe. That's going to be, the percentage is going to be really high, but I don't know whether FSSA goes ahead and tells the providers, you know, you need to pay your staff this percentage of that. Are you guys looking at?
So that is not a requirement in our regulations or laws today. You are correct that CMS has some proposed rules out there that one of those pieces is a pass-through requirement on a percentage of the rate that would need to go to direct wages. What I will say is when we built up these rates, we did put in very clear assumptions of this is what you will be paying your staff, and we will be posting all of that information. So it will be transparent, not just to providers, but to their staff as well. And our hope is that that additional rate and that transparency on how we calculated it will then result in that additional payment. And this ties to some other work that we're doing in FSSA as well, looking at the direct service workforce and how we can better support them, understanding that we definitely have work to do to make sure there is a sufficient workforce to support not only people who need services today, but the people we anticipate needing services over the next decade or so.
So that would be on your website.
There will be information on the website, yes.
Thanks. I got all my questions squeezed in. I'm sorry I was so late. We couldn't find a parking space anywhere. So we ended up in a parking garage, and I barely had enough room to get my chair through here, but I wanted to ask those questions in person because I didn't know how effective it would be trying to do it online, so.
Yep, absolutely. Thank you. I will defer the rest of my time to the other folks on the agenda.
All right. Well, thank you. And thank you for your questions. Erin, do you have a update? Okay, perfect. And then Kristen?
I had a lot of my updates via email as well. But I did want to do a fuller introduction. This is Linda Muckway. She's been on choice for how many years?
Since like 97.
Yeah. And tell them where you live. Muncie. So she's worked with Livestream Services all this time on her choice services. And you used to come to Indianapolis a lot more on a lot of these advocacy meetings, but it's been a long time, partly because of COVID and partly because transportation's a nightmare, right? Yeah, right? Coming all the way in from Muncie. And so, you know, Linda's been calling me with questions as well. And of course, I can only tell her as much as I know. So I think, you know, the public posting of all that will be important for advocates. One of the things that, you know, I wanted to make sure Linda and all choice clients know is, you know, are the availability of these meetings? And I don't know that if we specifically have a slot for a choice consumer on the choice board. So one of the things that I mentioned to Linda, especially now the meetings are hybrid, is she may want to consider applying to join the choice board. So I just want to raise these kinds of things up, especially now that some of the meeting dynamics are changing and it's more accessible statewide, especially for people who might be homebound and people like Linda who, you know, are, you have degrees in social work and right. So, you know, all our choice clients aren't older adults that just kind of are happy to sit at home. Yeah. You didn't have to tell them that. Yeah. Right.
I'm not able to fit into one of those categories.
Oh, there you go. Okay. Yeah. So just the fact that choice clients would know, you know, what openings are available and what some of the outlines of eligibility are. I think that might be something we want to consider advertising more broadly to try to get some actual consumer representation on the choice board itself. So is there anything else that you want to share with folks?
No, I just, like I said, my concern is I just want to make sure that the pay is low enough for staff to stay, you know.
Mm-hmm.
And so, you know, you get what you pay sometimes, and some of the people are really good, but some of the people are not so good. They're very disrespectful. Some of them smell like pot all the time they're in your house. They smell like that, even though they're supposed to be in your house. And what are you gonna do? You have whoever they have available, is who comes to your door. And I typically clients are home with breast.
Okay. Hopefully you just wrap up. Okay. So anyway, I just wanted to make sure Linda had a platform today when I saw her come in. The one thing that I did want to mention related to MLTSS is that, and especially since Shannon kept referring to this, you've heard us talk a lot over the last couple years about Enliven, and which is our network of area agencies on aging that does contracting with managed care. And for the purposes of pathways contracting, we are excited to, as the network, be evolving to a different organization that would do that MLTSS contracting. And Enliven will still be there, and we have current contracts in Enliven. But the new organization is called Community Care Hub of Indiana. It's a joint venture, primarily led by SACOA and Aging and In-Home Solutions. They are finalizing their board and governance by the end of this month. It's going to exist outside of the association. And some of the great synergies about that are that SACOA has been Enliven's manager for 1 million years since we started, and has worked with the AAAs in that regard. Aging and In-Home Services has done a lot, or been involved with a lot of national contracting. They were involved with Ground Game Health that went national, headed up with Connie as part of that leadership. And they, as a partnership, are also going to be able to bring to bear a high trust certified technology platform, which we currently don't have within Enliven now. And the platform we're using is not, I mean, it's HIPAA compliant, it's not high trust certified. And that high trust certification will be really important to the managed care entities. So there's going to be more information shared on that over the next couple of weeks. This is, Division of Aging knows, we've notified all the MCEs, particularly going into the roundtable meetings next week. So people know who they need to be talking with. But again, right now, this will be focused on the pathways contracts. So I just wanted people to be aware, because you might be hearing some of this from the area agencies on aging you represent, or from the managed care entities you're working with, et cetera. The other cool thing is that the one thing I forgot to mention is Aging and In-Home Services has been working on the community care hub concept since last year, and kind of working regionally. They got involved with ACL's Community Care Hub Learning Collaborative last fall. And so they're really able to kind of springboard that concept and move it to more of a statewide. So I think it's a really cool evolution for the network, and it's kind of the headline there. So the other couple things that are real important to mention, it's Older Americans Month, but we are celebrating our 50th anniversary of AAAs this year. And we celebrated the 50th anniversary of Lifespan Resources just this past Thursday. And I want to highlight Representative Clear, that had a major speaking role as part of the festivities there, as their current, New Albany's current representative. The legislators there helped to shepherd a House concurrent resolution in which they recognize Lifespan Resources. I also like to recognize Dr. Burke, who made it all the way down from Tipton, representing the Commission on Aging and Choice Boards. So it was a really, really great event. Finally, the other thing that kind of connected with that is that around this time, Golden Hoosier Award nominations open, and that's a long-standing joint recognition program for older adult volunteers between FSSA and the Lieutenant Governor's office, Lieutenant Governor Crouch. So, you can celebrate your older Americans in your life by nominating them for a Golden Hoosier Award. Some of the AAAs nominate, but it's an open nomination statewide that you personally can make a nomination for. So I'll stop there. Thank you.
Well, thank you, and happy 50th anniversary. And then Aaron, if you could look into see what openings we have for the choice board, to see if we could have like a choice advocate, what we have open, and we can make that known then, especially at our next meeting. Does anybody else have anything they want to discuss before we close? All righty. Well, may I have a motion to adjourn?
So moved.